We're going to be in chapter 49 discussing endocrine problems. The endocrine system communicates and coordinates with many systems within the body. As you know, it has a lot to do with hormone regulation. There's a lot of glands that secrete the hormones for our body to function properly. You see those listed. The hypothalamus, pituitary, thyroid, and parathyroid, adrenal, pancreas, ovaries, and pineal. We consider the pituitary gland the master gland. In the anterior part of the pituitary gland, that is where we have our thyroid stimulating hormone, ACTH, which deals with corticosteroids, our follicle stimulating hormone, luteinizing hormone, growth hormone, and prolactin. And then the posterior pituitary releases your antidiuretic hormone and your oxytocin. When it comes to the thyroid gland, T4 and T3 are very important. T4 accounts for 90% of the thyroid hormone that's made by the thyroid gland, and T3 is much more powerful than T4 and has greater metabolic effects. When it comes to calcitonin, which is also produced by the thyroid gland, it'll kick in when calcium levels are high in the blood, and then it will help lower serum calcium levels. So calcitonin and parathyroid hormone regulate calcium balance. The adrenal glands, located in the adrenal medulla, secrete epinephrine, norepinephrine, and dopamine in response to stress in our body. Cortisol is also another very abundant glucocorticoid. We need it to maintain life and protect our body from stress. The major function of cortisol is to regulate blood glucose, which goes hand in hand with the pancreas, which we already discussed last week, that regulation of insulin and glucagon. All right, true or false? Stress, burns, infection, fever, acute anxiety, and hypoglycemia increase cortisol levels. The answer is true. We're now going to move on to steroid therapy because many patients with endocrine issues will be on steroids. So steroids are, it's a great drug, but it has many, many side effects and potential complications. So it is effective in treating many diseases and disorders, but again, long-term use can have very negative side effects. So that's when we weigh out the pros and cons. Expected effects of corticosteroid therapy would be anti-inflammatory action. It does suppress our immune system, but it will also help maintain normal BP. And then the side effects are all listed here for you, but it can lower our potassium and calcium, increase blood sugar or glucose and blood pressure. Because it immunosuppresses, we can have delayed healing, susceptibility to infection, and then other side effects are also listed that you can read through. When it comes to being on a long-term corticosteroid, we teach our patients, not to stop taking them abruptly if they're prescribed them long-term, and monitor for signs and symptoms of infection. And then we teach our diabetics to watch blood sugar closely. The other things we teach our patients when taking corticosteroids is good nutrition, rest, physical activity, sodium restriction if they have edema, monitor their blood sugars like we talked about. We also teach them to notify their PCP if they develop epigastric pain that's not relieved with antacids. We also teach them about therapies to reduce osteoporosis because of that bone loss that can happen. And then we already talked about never abruptly stopping it. Here's an audience response question. You guys can go ahead and read through that. And another one. And then we're going to move on to Cushing syndrome. So with Cushing syndrome, this is a picture of a patient that has Cushing's. This came out of your book. This is a very classic presentation of what a patient may look like, that moon face. All right, and we'll go into this a little further. You can read through the case study. All right, so Cushing's is a clinical condition caused from chronic exposure to corticosteroids. Usually it's prednisone is the most common cause. Less common causes would be from a pituitary adenoma or a tumor in the adrenal gland or some type of tumor in the lung or pancreas could also cause a patient to have Cushing's syndrome. But generally, it's from long-term use from prednisone. This figure just shows you all of the different symptoms or assessment findings you would see with a patient with Cushing's syndrome. Another picture for you. This shows the striae, which are like stretch marks that can happen on the truncal area of the body. Manifestations of most of the body systems are related to the excess level of corticosteroids. Although signs of glucocorticoid excess usually will predominate for that patient. So the patient will have many changes in their physical condition, like in the last slide I showed you. Weight gain is the most common. It results from the accumulation of adipose tissue in the trunk. They also have the moon face. They have hyperglycemia because they've become insulin resistant. Muscle wasting, especially in the extremities. So they'll have very thin extremities. Loss of bone matrix, which will cause them to have back pain. And because they have decreased collagen, they'll have thin skin that easily bruises, and then delayed wound healing. This can also lead to hypokalemia and hypertension. They also will develop some androgen excess, which can cause severe acne and other changes in their characteristics. So what is our goal? We want to normalize the hormone secretion, and the treatment will depend on the cause of the syndrome, the Cushing syndrome. If it has to do with an adenoma in the pituitary gland, then they would have surgery or irradiation of that. Maybe an adrenalectomy would be necessary if they have a tumor in the adrenal gland. So it just really depends on the cause. If the Cushing syndrome is caused from the prolonged use of prednisone, then we wouldn't stop that therapy abruptly, but we would gradually discontinue it and decrease the dose, and then convert them to like an alternating day dose, every other day dosing, and taper it gradually. Objective data that we would see are possible diagnostic findings. They would have elevated cortisol level, abnormal ACTH. They may do a dexamethasone suppression test to identify the disorder that would be abnormal. They would have glucose in their urine, hypercalcemia in their urine, osteoporosis. So preoperatively, if they needed surgery, we would just need to make sure they were stable enough for surgery. Their blood sugar and blood pressure would need to be controlled. Their potassium would have to be corrected first. If they were to need an adrenalectomy, that would be a surgical removal of the adrenal gland. They would be in the ICU because they would be at risk for adrenal crisis, which would be an abrupt drop in their cortisol level. Signs and symptoms of that are listed for you: hypotension, tachycardia, tachypnea, nausea, and headache. So post-operatively, if they had an adrenalectomy, they would also be at risk for hemorrhage. And they'd have a large release of hormones that would be flowing into their circulatory system, which can cause those blood pressures, fluid balance, and electrolyte levels to be unstable. And they would receive high doses of corticosteroids IV during and for several days after surgery to help with regulation and inflammation. The patient, however, would be at risk for problems with their blood sugar control, infection, and delayed wound healing because of that. Postoperative care, again, we'd be monitoring them for acute adrenal insufficiency, which the symptoms here are listed. They'd be very weak. They'd have the GI symptoms, vomiting, dehydration, and then the blood pressure issues, hypotension, possibly pruritus, peeling skin, emotionally labile. So bed rest would be indicated, especially until their pressures are stabilized after surgery. You would monitor them for infection and meticulous care to prevent infection. So you would also let your patient know with Cushing's that postoperatively, once they take care of the underlying problem, that these symptoms that the patient's displaying should improve. So that should, boost their self-esteem and healing to know that these symptoms will improve postoperatively, and once we get their prednisone tapered down and get them off of it. All right, now we're going to move on to one more topic in this section, which is diabetes insipidus. This is a bit of a review because we've already discussed this earlier, but again, this is a low anti-diuretic hormone. So the urine is very dilute. Patient has polyuria. They can void liters and liters and liters of urine a day. They're very dehydrated, hypotensive when they have diabetes insipidus. We have to keep a very close eye on their fluid and electrolytes and the hypernatremia that this can cause. There's many types of diabetes insipidus. We have the neurogenic or central, which is a defect in the hypothalamus or pituitary gland. This can be caused from some type of brain tumor, surgery, head injury, or even possibly an infection. It usually comes on very quickly and acutely, and they have an excess fluid loss. They do a water deprivation test to confirm the diagnosis, and they'll see a rise in the osmolality in their urine after giving vasopressin, which indicates the disease. Then there's a nephrogenic DI. This is a renal response to anti-diuretic hormone. This is usually induced by the drug lithium. However, it can have a genetic display also. This is treated with a low sodium diet and diuretics. The indomethacin will help increase renal responsiveness to the anti-diuretic hormone. So this is only in the nephrogenic phase. Primarily, it's caused by excess water intake, lesion in the thirst center, or it can even be a psychological disorder causing the DI, or the patient just continues with this behavior. Key features, polydipsia, polyuria, which leads to weight loss, constipation, poor tissue turgor, hypotensive, tachy, shock, irritability, and then they can have those central nervous system signs and symptoms from the hypernatremia. All right, nursing interventions. So IV fluids to replace urine output, or PO if able. They may give DDAVP, which is desmopressin or vasopressin for central DI. Tegretol may also help with the thirst associated with central DI. We monitor level of consciousness, urine output, I and O, and then it's really important to know that the patient must be weighed daily for drug management for drug management for these patients. These patients are acutely ill, so besides weighing daily, monitoring level of consciousness, urine output, BP, and pulse, those are the primary nursing considerations.